The mobile renewal platform for NHIS is a year old. Tell us how that journey has been.
It's been a fantastic journey. It was designed to solve a challenge. Our members were spending between 9 and 11 hours in queues trying to renew, inconveniencing everybody. They made it clear to us that the solution had to be something they could do themselves. So we came up with the *929# for them to renew themselves. In 1 year, more than 5 million people renewed themselves in the comfort of their home. It has solved challenges for us, no queues at our district offices anymore, allows us to get out and about, educate the public, register people in marketplaces, offices. So it's been a bonus all round, saved us some ICT costs around registration and renewal. It's been good.
So what's the next step for you?
Well, the renewal then triggered an authentication. So all the hospitals and clinics use, again, mobile technology to authenticate every visit. That gives us, as a nation, real-time utilization on patients across the country. Now, this is useful for the ministry, our partners, development partners, and ourselves to really tailor the healthcare needs to fit what the population wants. Then the third step was a feedback loop from the members. They asked that they want to be part of the accountability process. We send an SMS to every person that a clinic is going to make a claim in their name. And some of them, once you press 2, it means you didn't attend. And some of them are actively following up to say, I haven't been here. Don't pay them. And the consequence is 2 facilities have been shut down, or decredentials, I should say. So all in all, it's just spawning more and more work around mobile technology and improving the efficiency of the NHIS.
So this is also looking at finding a way to combat fraud within the system.
Yes, it is.
Yeah, let's zoom in a bit on that and tell us how these, for instance, you discovered these 2 facilities and what exactly.
Well, the mobile renewal incorporates a feedback loop. Because we don't write on the back of the card anymore, the hospitals had to be given a way to authenticate. So they have a different number, not 929, it's a different number. And that identifies the clinic the authentication is coming from. We give them a code, which you put on your claims form for payment. And the public insisted that they want to be part of this process. Be a citizen, not a spectator, as our president said. And what happens is, when the hospital sends to authenticate, whatever phone number is attached to that member, we send them an SMS. If you are not there or have not been there, you just press 2 on your phone. It's all you need to do, no cost to the member. And what is happening is they are pressing no. And some actually call our call center, which is 6447 short code, to say, I got a message, I haven't been there for 2 years, look into it. And this is just, it creates an inclusiveness. Citizens feel they own the scheme. So the mobile renewal has been a really good thing.
And have these persons discovered been handed over to authorities since this could be fraud?
Yes, we went, investigated. So the report has now come to my desk. We've written to tell them that they're off health insurance, and we'll take the next steps, appropriate steps.
Which is hand over the dockets to the authorities, the law enforcement agencies?
Well, actually, we have the fiat from the Attorney General to do our own cases. So we will follow the due process.
Right, so tell us a bit more about the health insurance scheme in general and some of the successes that you've chalked.
Yes. So this year we've crossed the 12 million barrier. So we're now at 12.1 million active members. excuse me, we have 22 million in our database, which means potentially today they could all activate themselves by mobile money without coming to our offices. So this week we're going to do a massive blitz across the country. We're asking everybody to carry their NHIS card with them. Our staff will be all over the country encouraging people to activate their membership.
We have heard some claims from service providers about how there's a delay in the payment of their claims.
As explained by the President in his press briefing, yes, there's always a lag. The claims we are receiving now for reimbursement are people who attended clinic in September 2019. Those documents are now coming for us for processing and payment. So we can say we owe up to September, no more than that. We've paid a lot of people May. April, May is the level we're paying now. So in reality, we owe June, July, August, September, 4 months. At some point, we owed 15 months a few years ago. So we have closed the gap remarkably, and we're working very hard to narrow that down completely.
The Private Healthcare Facilities Association of Ghana on Friday released a statement saying that for only about 30% of their members had been paid. A number of them were still owed 10 to 12 months.
I find that very hard to believe. We have set up a dedicated email address, which we've passed to all of them. If you feel you are owed longer than others, you just send an email to us. There's a dedicated team that will investigate why. I know they put out a statement, but they themselves retracted it within 24 hours. So we are in dialogue with everybody. We have a lot of stakeholder meetings. You know, we like to be in good harmony with everybody we work with. We're all stakeholders on that UHC journey. Nobody is bigger than anybody else. We all have a part to play. So we're trying very hard to keep up communications.
So the publication I read was not a retraction of their claims. It was just they decided not to go cash and carry anymore.
Yes.
Yeah. So does that mean they have been, but in your words, they have been paid?
We pay every day. We pay every day. But on talking to them, they themselves realized that some of what they put out there was not quite right. So we're dialoguing with them. We're paying every day. And, you know, it's a process.
I love the way technology has really changed the way the NHI is doing things. I was speaking to my friend, the doctor, and he was talking about how hospitals can now submit their claims to NHI electronically.
Yep.
Can you shed some more light on that?
Yes. We obviously, market forces, there are a few vendors who have developed electronic software. And then we also developed in-house a software we give to providers for free. We've got a back end that accepts the claims. So once we published what they call XML standards, any vendor that fits those XML standards, we will test it out and we can accept the claims. So the back end is ready. We have given our software to the smaller facilities who may not want to buy software. So about 25% of our providers have gone electronic. There's one that the major hospitals are using. All the teaching tertiary hospitals, Kolebu, Cape Coast, Komfanochi, they have also gone electronic. So it just makes it easier for everybody. We don't have all that paper. And it's easier to process the claims because the business rules are in there. The computer can check all those things, flag up any that require personal intervention. So we hope that it will make things a lot faster. But more importantly, the data. The data allows us to understand the health needs of Ghanaians. On paper, you can't do that analysis. And as we monitor the trends, The country needs to respond to the health needs of Ghanaians. Things are changing. The infections, malaria, abscesses, boils. We're now looking at hypertension, diabetes, and some of the cancers. And we need to be able to respond to that.
I was going to actually go to that what we are learning from the data, but we'll touch on that a bit later. So this issue of when they submit vis-a-vis when they are paid, the question that I get is that those who don't get access to this system, when they submit, the claims don't come to Agbelempe early enough.
No, we have 4 claims processing centers. So you can submit to your district office, as they used to in the past. The district office will carry them, or you can submit yourself. We have enough staff. We don't have massive challenges in that area.
So the 90-day waiting period is from when it goes to the district office?
Yes, the 90-day waiting period is when the provider brings us a bill and it's accepted.
At any of your offices across the country?
At any of our offices across the country.
Okay, so that means for me that if a hospital says that they have gotten a delay in claims, it is from when we should count from when they went to submit
When they submitted the claim. You cannot count from December. Nobody has brought December. I don't think anybody has even brought November. 1 or 2 have brought October. The bulk of what is coming in now is July, August, September claims.
Apart from the delays, what informs, the delays in submission, what informs the delays in payments?
Oh, there can be delays at every step of the process. Some people have not renewed their credentials, and the credential checks, the staffing, the equipment that you have, qualified healthcare personnel. Some people don't bother to check that their credentials or even their license with the health facilities regulatory agents. Some people just let their license, even to practice in the country, lapse. When that happens, at our end, it shuts you off and we can't even pay you until you sort that out. In order not to have, what's the English word? Kululu going on. The system automatically shuts you off when your license expires. This the finance system, and you can't be paid. So sometimes, we have to then do a lot of back and forth for them to get their license, renew their credentials here, and then we can pay them.
That means that for these issues, we should be able to put a number on the number of facilities we have issues with, right?
Oh, we know that.
How many?
Oh, I'm not going to. I'm not going to bring that up here, but we know. For everybody we haven't paid, we know exactly why. Sometimes there are even bank account issues. We've moved to the gift miss, and the gift miss is very particular about your bank account, where it is, and who are the holders. So again, some people have been affected by us moving to gift miss because their bank accounts were not quite kosher. So all that is being sorted out.
So with the migrations to gift miss as well adds to these challenges?
It caused some delay for some people, but we're working on it because all your documents must be kosher for you to even be loaded as a supplier of gift miss. So,
are we able to say confidently that we don't have cash flow issues for the NHIA from the source?
Everybody has cash flow issues.
Tell us about them.
So, everybody has cash flow issues. It's about prioritization. We try to ensure we maintain what we call an acceptable medical loss ratio, as in what goes into claims and health services as to what goes into administrative expenses. And we try to balance that out. But there are competing issues. But we really do try to prioritize. We have, reduced from 15-month gap to a 5-month gap. We're doing quite well. There also has to be some, on the other side, when we pay, they must also prioritize, pay their pharmaceutical suppliers and other things, so it's prioritization all along the way.
I was asking about cash flow because we know the Health Insurance Act mandates the NHI to set up a fund to, manage the monies that is collected. Tell us about the management of that fund. This is an insurance, basically an insurance fund, isn't it?
So we get money from three main sources. The 2.5% levy by law, which constitutes 70-75% of our income. 2.5 percentage points of SNCC contributions. And to make it clear, your pension is calculated as if that money never came to NHI or NHIS. Those two constitute about 90% of the fund in the past. And then we have premiums and processing fees, and then investment income. Obviously, in lean times, you don't invest as much as you might like to ensure the providers are paid constantly. But the mobile renewal has increased our premium and processing fee. So this year, we will see the balance shifting a little. So under the laws of the country, all taxes go into the consolidated fund first before coming into the health insurance fund. So we have to wait for it to come. So
how long does it take typically for it to hit your account?
Yeah, it's difficult to tell because I don't know when it's collected. But we, one good thing is we all keep very good records. So we know at any time T what is due us.
How much investment income have we made?
I can't tell you off the top of my head. 2016, 17, 18 were slightly lean years, as in we didn't want to invest too much because we were a bit tight. Now we make an effort to, even if it's only a couple of million, we are trying to build up an investment portfolio.
Shouldn't that be the focus so that we can even build in excess?
Yes, but we owe providers. How much do I put in investment when we owe? So it really is a delicate balancing act.
Have you compared how much you take in the 2.5% in a year and how much you receive in claims?
Yes. We have an actuarial model which has just been built. So all those things are factored into it. We are sustainable. It depends on so many factors. The timing of the releases, the completeness of the releases, medicine prices is one of our biggest challenges. The way we pay is another challenge, as in case-based, fee-for-service, because they all have their disadvantages. If you do fee-for-service, obviously people just consume services they don't need to make payments. So sometimes you have to use other methods to clamp down on those kind of things. So what I want to say is our actuarial model tells us we are very sustainable, but we have to be disciplined as a country. I have a scenario that paints a 30 billion CD surplus by the year 2034. But then there's a scenario that has a deficit by the year 2029. It depends on how, the levers we pull. So it's up to us whether our scheme is sustainable or not.
Just so we understand it, when you say 30 billion surplus, you mean a 30 billion excess after we've paid the claims,
exactly.
Have 30 billion CDs?
Yes, by 2034. It depends on the decisions we take, the medicines we will pay for, the diseases we will cover, how many people, the more people we have on board, the better off we are, because the healthy are subsidizing the sick. So all these factors must come into play, but we are sustainable based on the actuarial model.
So what does the model tell us? How much money do we get in and how much? Can you give us the actuals, the figures?
Yeah. What the model, we base our projections on what we think, or the estimated economic forecasts of GDP, how many people will be in the formal sector, their wage structures, so we can put all that in. We look at the disease burden, our population, the cost of drugs, how we expect that to go up with inflation, the cost of services, how we expect that to go up with inflation, and all that is fed in. Then we add extra diseases to see if we were to add prostate cancer, what would happen to us? If we were to take out something, what would happen? And all this is factored in. So there are different scenarios. And this is where I believe we should probably take it to the public next year and really educate people. These are the scenarios. This is what makes us sustainable. This is what puts us into trouble. As a country, what do we want to do? What will benefit the greater population? If you go for a niche disease, that only benefits a few people in Accra, but costs so much. Is that what is good for the country? Or you go for something that affects everybody, can even be diagnosed in villages, the treatment can reach everybody and helps the greater good. So hold the questions. In the new year, we will educate everybody and have proper national forums to throw this out there, and let's see what Ghanaians want their national health insurance scheme to
I'll
do.
hold the rest. I just have two on this. Your former CEO advocated a 1% increment in the NHIL levy.
I will never turn that down if it comes, but we have to look at the bigger macroeconomic picture of the country and the fiscal space.
Is it in your model, your 30 billion by 2034 model?
Yes, we did that. We put that in as a possible scenario, but it isn't a main scenario. We've really concentrated on the 2.5%, but getting all of it in a very timely fashion.
So if you don't get that one, NHIS is sustainable?
Yes, it is sustainable. It also depends on what diseases you want to cover.
My second one is on the 2015 review that was done at the Mahama government, where they said that, look, let's take some diseases off and let's focus on some others. Your views on that?
Our benefit package is a bit loose, as in it has an exclusion list and not necessarily an inclusion list. So it's about really defining the inclusion list very well. It's not so much taking things off. It's about defining the inclusion list very well, so we all know this is what it covers. When you go to the hospital, you don't pay. And that is what is important. We want to focus on primary health care and prevention. You know, treating somebody with a stroke is so much more expensive than catching the hypertension early and giving adequate treatment at that level. The same with diabetes. You know, we have gangrenes, amputations, it becomes expensive. Why don't we treat them early and control the diabetes? And most countries that go that way, their schemes are more sustainable. So I think that is what the review is talking about. Not so much taking things out, but trying to concentrate on the early stages, early breast cancer, early childhood leukemia. It is so much more cost effective to do it at that early level. And that's what we need to do.
What does that mean for the people who already have the extreme diseases that are very expensive? Do they get
That's all right,
treatment?
we will still treat them. But it means there'll be less of them. And there won't be so many more adding to it.
So it is not a policy for the NHIA. It's not something the NHIA supports to take some of these expensive diseases off the coverage of NHIA.
Not at this time. I don't think we're covering anything that is out of our reach. We have added a new breast cancer drug, Herceptin. I think we're the only sub-Saharan African country that's put it on its health insurance scheme. So it's about, you know, how you run it. We've done a good PPP with the manufacturer, so but we have to track every vial to make sure it goes to a patient who needs it, and it's the early results are very, very positive.
Speaking of drugs you buy, Another complaint you get from hospitals is that your prices are too low.
It can't be. Read WHO reports on medicine prices across the world. Ghana is always the #1 country for expensive drugs. World Bank, all our partners are telling us to do something about it. The government removed all tax on medicines. Those who bring in the drugs and make it didn't budge on the prices. Now, in every country, you use your health insurance scheme as a payer to promote the change you require. If we cannot use our financial muscle to bring improvement into the pharmaceutical supply chain, then we failed. And as we cause improvements, then the ordinary man who also walks into the drugstore to buy will benefit.
Can you see the same for services that are rendered?
Services, we did a 20% increment this year, wholesale across board. But along the line, we are running faster than the inflation of the country. The NHI's costs are running higher than the inflation of the country. So there's some extra added pressure on the scheme that is unnecessary. Again, most countries use the single payer to foster change within that sector. And we need to, the discussions are ongoing. We have health sector working group meetings. We need to use the single payer to improve quality, to improve patient safety, and to bring down prices. And we're working on it.
This 20% increase was the first time in 4 years?
Not at all.
5 years?
Not at all.
When was the last increment before this one?
I think in 2016, we increased prices.
So if I'm going to strike it across 2016, 17, 18, so it's 4 years. If I'm going to strike it across, it's 5% per year. Inflation for some of these years
no, but
is 17%.
Before that, we had done 25% like for 2 or 3 years running.
Well, I mean, if you
I need to double check on the 2017 as well.
Wait, so when I get to the hospital now, I understand from the breakdown I get that I pay 19 cedis for consultation. Will 19 cedis cover the services that the doctor renders?
His salary is paid for. The building was built by the government.
What about private hospitals?
They are paid a different tariff. We don't pay.
I'm quoting 19 for private hospitals.
No, maybe I can't remember.
I just spoke to a doctor. It's 19 cedis.
Then he's either a maternity home or a health center. Private clinics get paid something different. Private hospitals get paid something different. So it's a breakdown of the building blocks that come up with this figure.
So, doctor, with let's finish off with the conversation we began with, which is how technology is going to infuse a change in what we are looking at. You've gotten new data, you've gotten new customers. Where are we going?
Well, the data, we're doing a lot of data analytics at the moment to show who our members are, what happens to them year on year, to really see how we target to keep them on. The health needs are being analyzed, utilization. The last figures I had, over 150,000 people attend hospital every day with an NHIS card. So it is a need, we shouldn't pretend. Now, the efficiency within the sector has to be improved. We have done a survey that shows the #1 reason why people do not renew is staff attitude when they go and being asked to pay money at point of service. Those two must be eliminated within 2020. That is the way to get everybody back on board. The technology the analytics are so exciting. We will begin to share some just for the public to really appreciate what is going on so that we all put our hands together on this.
Dr. Dsane-Selby, thank you very much for your kindness bringing us into your office like this.
Thank you very much for coming.
This conversation brings us a full understanding of how we pay for our visits to the hospital and how our taxpayers' money is used for. Most exciting, of course, being what technology is doing to improve that thrive or that strive towards universal health coverage. Still live on the JoyNews channel. I am Daniel Dsane.